Dr. Melany Su is a family physician practicing broad spectrum family medicine at El Centro Family Health and Presbyterian Española Hospital. Having completed medical school in New York City, residency in Southwest Missouri, obstetrical fellowship in the Detroit area, and now practicing in rural New Mexico, she has enjoyed learning and living in a great variety of settings. Also a National Health Service Corps scholar, she is passionate about addressing health disparities and caring for underserved populations. With that said, Dr. Su, thank you very much for joining us today, and the floor is yours.
Thank you for having me and for the introduction. Let me see if I can share my screen again. Does everyone see this slide, first slide?
Yes.
Yes. Okay, great. All right, so my talk today will be essentially an overview of prenatal care. So these are the learning objectives. And so my goal for you today is not actually to memorize all that you need to do for every prenatal visit, because to be honest, you can easily look these up, and I'll show you or I'll share with you some links and resources that you might find helpful in your day-to-day practice. However, instead, my goal is for you to understand why we do the things we do, and also keep in mind there's much of prenatal care and obstetrical care in general that is still very much based on tradition rather than evidence. And so I will be highlighting these differences and the elements that are backed up by evidence. There will be an asterisk next to the point, just so you know. Okay, so I think our audience today is mostly family medicine physicians, and some of us may not continue to provide OB care after graduation, but there are still reasons why we discuss prenatal care. So first of all, there are some sobering statistics we should be aware of. Unfortunately, maternal deaths in the US have been increasing since 2000. And among developed countries, the US ranks the highest in terms of maternal mortality, has an undersupply of maternity care providers. All of that despite spending the most, or compared to other countries, the most of its money on healthcare. So here's just a slide showing you maternal mortality rates across the world, and you'll see that these are mostly developed nations. And unfortunately, the US still ranks the highest at 22.3 per 100,000 live births. And this was from 2021. And if you look at the number for the US Black population, the number is even double or more than double the national average. Now, there is another reality to keep in mind. So family physicians are well positioned to improve the health of pregnant women. One reason is we deliver babies in many places in the US, so more than 40% of all US counties. This chart at the bottom, so this map shows you maternity care deserts in the country. These are counties where there are no certified nurse midwives or OBGYNs providing maternity care. And in 16% of these maternity care deserts, family physicians are the sole maternity care clinicians. So they serve in these counties more than 400,000 women. And so all that to say, yes, maternal mortality is rising, but family physicians, we do, many of us take care of pregnant women, but even of those who do not, we invariably will come across women of childbearing age or women who have had children. So there are two frameworks that you can potentially use to approach prenatal care. The first is what I would call like a chronological approach. So you're welcome to scan this QR code. I made a worksheet of different items you might use during your prenatal visits. And essentially, it's just a timeline of different items you might do. Another way to think about prenatal care is what I would call more categorical approach. So different items or different categories of things you might do for these women. And for the sake of this talk and just the way things will flow, I think this is just makes a little bit more sense. So this is the way I will be giving my talk. And I'm also looking for volunteers for anyone who would like to just read the case, if anyone feels up for it. If you do, feel free to just read this case for me.
I can read the first case.
Go ahead.
So case number 1, a 26-year-old G1P0 presents for her initial prenatal visit. Based on her last menstrual period, her gestational age is 9 weeks, 1 day today. She shares that she has never been to a healthcare provider since becoming an adult. She has regular periods and is sure of her LMP. Which one of the following statements is false?
So here are your options. And I will be giving you all about 20, 30 seconds just to think about your answers, and then we'll talk about it. And thank you, Dr. Reyes, for taking the first case. So hope everyone has had a chance to just think about your options. So I would say the best option here is probably number D. And this takes to my first point of this talk, which is sometimes it's easy for us to think about pregnant women as one population group and everyone else as a different population. And while there are very many pregnancy-specific guidelines, there are still many other medical care items that remain the same. Something to keep in mind is that around 30% of women diagnosed with cervical cancer are in their childbearing years. And so a pregnant patient who is due for a pap smear ideally should have it done. Technically, colposcopies and cervical biopsies can be safely performed during pregnancy, but you should definitely defer endocervical sampling until postpartum. I would also say that most of the OBs I've worked with would defer a colposcopy to the postpartum period, and that's usually acceptable. And then we'll go over some of those few options in the next few slides. So physical exam items. First is just obtaining a weight and height at every visit. The main goal of this is monitoring for weight gain is important to prevent certain adverse pregnancy outcomes. And I've just included here, as you see patients, it can be helpful to just keep in mind their goals for gestational weight gain and also how their weight gain might inform your nutritional counseling. Obtaining a blood pressure at every visit. So this is to assess for any hypertensive disorders in pregnancy. Now, urinalyses are actually not so much evidence-based. They do not reliably detect proteinuria and early preeclampsia, and also glycosuria is not really reliable for detecting gestational diabetes. Now, having said that, if you do notice a patient has proteinuria plus elevated blood pressures, that can guide your management. And similarly, if you see glucose, like a ton of glucose in the urine. And dental exams are recommended early in pregnancy at least once. And if there's any periodontal disease, early treatment has also been shown to decrease adverse pregnancy outcomes. Fundal heights starting at 20 weeks for monitoring. Fetal Doppler tones starting between 10 and 12 weeks, but should be able to hear this by 12 weeks. And then obtaining fetal presentation by 36 weeks gestation. And then obtaining a pelvic exam is helpful early on in pregnancy just to assess for any reproductive tract abnormalities, also as clinically indicated. So, for instance, if you're concerned about increased vaginal discharge that patients tell you about. And then also for routine pap smears, as we discussed earlier. Now, the next section, we'll talk about ultrasounds. So there's a whole list of reasons why you might be doing an ultrasound assessment, and this is just a non-exhaustive list. But some specific reasons might include confirming dating. So the patient does not have an LMP that is certain, if their periods are irregular, there's any uterine size states discrepancy, it's helpful to accurately obtain dates so that you can then provide the appropriate management for their gestational age. Obtaining an ultrasound before 24 weeks has also been shown to help us avoid missing multiple gestations, but also avoiding post-term inductions, especially when the LMP is unsure or not reliable. And then routinely we do a fetal anatomy screening between 18 to 22 weeks. And then if you're not able to adequately assess fetal presentation, then ultrasounding is important. I will say in my own practice, I also just ultrasound everyone at 35 to 36 weeks because sometimes with maternal body habitus, it can be difficult to perform an accurate physical exam. So here's another case. Would anyone else like to read?
I can read it.
Thank you.
A 19-year-old G2P1 transfers care to you from out of state. She is 32 weeks gestation today, and it is December. She is up to date on all her childhood vaccinations, except she has only received one HPV vaccine at 12 years of age. Her prenatal testing shows she is rubella non-immune. She has no chronic medical conditions, and she has not received any vaccines this year or this pregnancy. She received the Tdap vaccine 2 years ago with her prior pregnancy. Which of the following vaccines can or should be offered to her today?
So these are your options. And again, I'll give you all some time to think about them. Okay, so I would say the most appropriate answer, in this case, I would say is C, and we'll go over immunization guidelines. So there are two pregnancy-specific immunizations that are recommended. The first is the Tdap vaccine. And you can give this really anytime, but preferably between 27 and 36 weeks gestation. The reason for this is we like the pertussis component, which has been shown to prevent their infants once born from getting pertussis and being admitted to the hospital. And so the way I explain this to women is we're giving you this vaccine for your baby, and once your baby is born, the antibodies that you produce will be passively transmitted to them so that they're protected from pertussis until they get their own vaccines. The RSV vaccine has conceptually is similar. So again, you're protecting the baby once born. And this one actually just came out pretty recently. So the FDA approved it last year in 2023. And if a pregnant woman hasn't received the RSV vaccine, then just so you know, there is a monoclonal antibody available for infants whose moms did not receive the vaccine. Then the influenza vaccine, as with all adult patients, is recommended for pregnant women during flu season, has been shown to reduce the risk of hospitalizations and adverse outcomes, both for mom and baby. And then it's also recommended that women stay up to date on their COVID vaccines and receive at least one bivalent dose. Now, there are a few vaccines that are not recommended or are contraindicated in pregnancy. And those include the live influenza, so the nasal vaccine, the MMR, varicella vaccines, and then the HPV vaccine. And here on the right, you're actually seeing part of a table that I took from the CDC. It has a nice page with just different vaccines and different medical conditions. So this is one helpful resource you could refer to read more about individual vaccines and just different topics you can provide for your pregnant women when counseling them. And the rubella and varicella vaccines, even though they're not recommended during pregnancy, it is recommended that you screen for them for immunity. And then if they're not immune, to offer those during the postpartum period. And the goal of this is to prevent future pregnancies from being affected with congenital rubella or varicella. So going back to our patient, she is 32 weeks gestation, so she is prime time for getting the Tdap and RSV vaccines, and it is December, so the flu vaccine, if she hasn't had that, as well as the COVID vaccines. She said she's only received one HP vaccine, and so she's due to complete that. And she's also rubella non-immune. However, those two vaccines are not recommended during pregnancy, but you can offer those during postpartum follow-up. The fact that she received the Tdap vaccine 2 years ago actually is kind of a red herring, because you do want her to repeat the Tdap vaccine for the pertussis component every pregnancy. Okay. So I just want to take a quick pause and see if anyone had any questions before I continue. So next we're going to talk about lab tests. So with your initial visit, you'll be getting a whole host of different labs. First is a blood type, so type and screen. And this is important because for Rh negative women, it's important to administer the RhoGAM as clinically indicated in that 28 weeks to prevent alloimmunization of their babies. Then infectious labs, we have the lists is over there, but I also just wanted to mention the rubella and varicella immunity that we talked about earlier. Obtain in urine cultures, so asymptomatic bacteriuria is not something we routinely treat for in adult non-pregnant patients, but in those who are pregnant, treating asymptomatic bacteriuria does reduce the risk of recurrent UTIs, pyelonephritis, and preterm labor. Finally, obtaining a blood count and treating for anemia is also important to reduce the risk of adverse outcomes. There's some additional testing you'll be obtaining later. This includes the CBC that I usually repeat at third trimester, but also as clinically indicated. So the patient tells you they're suddenly feeling very tired and have just shortness of breath, even on doing mild exercise, for example. And then if they come in with symptoms, for instance, new genital lesions or vaginal discharge, you might be obtaining additional tests. And then syphilis is on the rise. So we do rescreen for syphilis at least at third trimester and when the mom is admitted for delivery. But also repeat other STI testing if there are concerns for re-exposure or if they have a history of recurring STIs. And also if you have screened and treated them for, let's say, gonorrhea, it's recommended that you then obtain a test of cure to make sure that's been adequately treated. So all pregnant patients should be offered genetic testing, specifically aneuploidy screening and neural tube defects. This can be done with blood work, often in combination with ultrasound. And all pregnant women, regardless of their risk factors or their age, should be offered those too. Then there's also additional genetic or carrier screening based on parental history, and those can also be offered. Now, I'm just going to share with you this table. Just you can look at this on your own once the slides are posted for different options for aneuploidy screening. And then here's a chart from ACOG, which also includes a timeline of when these tests can be done. So metabolic tests, those include TSH. This is not routinely or universally recommended, but you should test if there's a history of thyroid disease or if a patient's symptoms make you concerned about thyroid disorder. And this is because untreated hypothyroidism or hyperthyroidism have been shown to be associated with adverse pregnancy outcomes too. I do want us to keep in mind, especially with the population we serve, but even overall in the US, that there are risk factors for gestational diabetes and preeclampsia. These can be quite prevalent. So here's a chart just showing you those risk factors. And routine screening for gestational diabetes is recommended between 24 and 28 weeks gestation with a 1 hour glucose tolerance test. And then the second step is if they screen positive, you will be obtaining a 3-hour test to confirm the diagnosis. But if there are risk factors, you would consider screening early with an A1C, fasting blood sugar levels, or even an early 1 hour glucose tolerance test. For patients who have risk factors for preeclampsia, it may be helpful for you to obtain baseline screening for thrombocytopenia. So this should be included in your CBC, but also transaminitis, renal insufficiency, proteinuria. Now, low-dose aspirin, I feel like is an important topic too. In our primary care world, we know the great evidence that low-dose aspirin has for secondary prevention of cardiovascular disease. But now in the last few years, I'm sure we've all heard with primary prevention, it's shifted more towards a shared decision-making model. However, in the OB world, low-dose aspirin still has great evidence as far as reducing rates of preeclampsia, preterm birth, fetal growth restriction in patients with risk factors. Starting at 12 to 16 weeks gestation, they should be given those or given the aspirin to take daily. However, at the same time, one important area of quality improvement is that many patients who have these risk factors do not actually get aspirin or are not offered aspirin. So this is just encouragement for all of us to think about your patients and who might benefit from aspirin. So here's a chart showing you the specific indications. The first half of the chart shows you higher risk factors. So these are women with who, if they have just one of these risk factors, they should be offered low-dose aspirin. The bottom section would be women who, if they have at least 2 of these moderate risk factors, they should also be offered. Okay, case 3. I'll read this real quick for us. So you see the following women for prenatal care today. None of them had yet been screened for GBS colonization. Which of them should receive the vaginal rectal swab today? And here are your options. So the best answer I would say is B and D, and we will be going over GBS screening here. So why do we screen for group B strep colonization? When we used to actually not universally screen women for group B strep disease, and when we started screening them and offering them intrapartum antibiotic prophylaxis for those who test positive, we've been able to reduce the incidence of neonatal group B strep disease by 80%. So those implications can include respiratory distress, apnea, pneumonia, shock, and meningitis. So it was great, really important thing that we did for newborns. Now, whom should you screen? So these are women from 36 to 37 weeks gestation, regardless of planned mode of birth. Now, this is a recent change in terms of guidelines. Previously, it was at 35 weeks was when you could start screening. But the reason they changed this was the group B strep culture is valid for 5 weeks, and some women are still pregnant at 41 weeks gestation. So it's thought that by pushing this window to 36 weeks gestation, you're accounting for that last week between 40 and 41 weeks. Now, having said that, if you see a mom who has been screened more than 5 weeks prior to delivery, you should consider rescreening when you see them, let's say, in labor. Also consider screening sooner if you're anticipating delivery within 5 weeks. And then screen all patients who present in preterm labor or have PPROM. This probably applies more to the hospital setting. Now, whom do you not screen? So these are people who are pregnant women who had GBS bacteria identified at any time in pregnancy. And this is because having GBS in your urine already represents heavy maternal vaginal rectal colonization, so automatically they should be offered intrapartum antibiotic prophylaxis. When you test your pregnant patients, make sure to ask about if they have any allergies to penicillin and a specific reaction. And if they do have an allergy, the culture or the lab should send a culture for susceptibility if the GBS ends up being positive. And this is to help guide you on antibiotic choice when they do come into the hospital. So going back to our case, patient in option A, she had group B strep bacteriuria, so you do not need to screen her again. Person in B is right at that gestational age where she would be screened. C, she doesn't need the screening today, but you can do it at the next visit. In D, even though she's just 35 weeks, she has a planned scheduled delivery at 37 weeks, so she would be someone you can screen today or should screen. And this is just a chart. I'm not going to read all of this for you. You can refer to this on your own. Just who needs antibiotic prophylaxis once they are in the hospital. And here's another chart just telling you which allergy reactions are considered low versus high risk. And another chart just showing you the different options for antibiotic treatment if they have an allergy to penicillin. Okay, so this is our second to last section. So social determinants of health, they represent up to 80% of the risk factors that directly affect a person's health. And this is just in general, not just in pregnancy. In New Mexico, unfortunately, mental health disorders and overdose are the leading causes of death in pregnancy. So here's a report from last year from the Department of Health. And as you can see, mental health conditions, and here showing overdose, are among the top 2 reasons why pregnant women die. And so screening for depression and anxiety is recommended at least in the first and third trimesters using validated tools that I've listed here. And at the bottom, I'm showing here also depression and anxiety that are untreated are also associated with significant pregnancy outcomes. So food insecurity also should be screened for at least once during pregnancy and at least once in the postpartum period. And you can use very easy and simple hunger vital sign tool. Intimate partner violence probably should be screened in everyone, but certainly anyone who might become pregnant at the first prenatal visit and at least once per trimester. So substance use, you would ask about this routinely as indicated and in the first prenatal visit. There are multiple tools you can use to ask about this. And again, we probably all know substance use, including alcohol use, are associated with adverse outcomes both for mom and for baby. Now, with all of the above, it's probably obvious, but if they screen positive and you do more assessment and you are concerned about any one of these items that we talked about, then it's important that you intervene. This can include counseling about the effects of substance use, assessing whether they are ready for change, or providing information about resources, or referring them for treatment. In our clinic at El Centro, we've implemented something called SBIRT. I imagine other clinics may be doing this too, and it stands for Screening, Brief Intervention, Referral to Treatment. This is actually a measure that has great evidence in reducing and preventing substance use and substance use related problems, and also is reimbursed by insurances. So lastly, we will talk about education. So I think of every prenatal visit or contact as an opportunity for education. And your topics can include anything from breastfeeding to gestational weight gain to medication use. Now, I won't read through all of this again, but just wanted to highlight this. This came from an article that I'll be referring to at the end. And it just includes tables on different points that pregnant women might ask you about. And there are references in the article that you can look up and just talk to your patients about. Another topic that pregnant women often ask me about is safe medication use. So previously, the FDA used something called the pregnancy category system. You may have seen this before, and they discontinued it in 2015. The reason was they thought this system was a bit too simplistic, and people often relied on just looking at the labeling, the category, and may not have considered all the nuances to the labeling. Instead, the FDA switched to the new pregnancy and lactation labeling rule, which includes a narrative summary of risk, data, and clinical considerations for individual medications. Now, what I personally have found useful, I would like to share with you a few resources to help you access this information. The first on the top left is an article in the American Physician Journal. And you may have come across this, it's just from last year. It just has a very accessible review of common over-the-counter medications and different tables and lists you can refer to. Bottom left is LactMed. So this is a database created by the NIH. It is peer-reviewed and free. The only downside, I think, is that it often has lengthier articles, so it can take a little bit of time to see through information. Top right is the infant risk app. So you might find this more useful on the go. Just as an FYI, I am not sponsored by Texas Tech, but it is a paid resource. But again, it provides short summaries with citations on different exposures and medications. Now, bottom right is a website called Mother to Baby, and this is a free resource that is user and patient friendly, and it has fact sheets on more than 275 different drugs and exposures and their impact on pregnancy and breastfeeding. And another positive note on this is that Spanish versions are also available. So you can refer your pregnant woman also to this resource if they'd like. Okay, so here is our last case. Would anyone like to volunteer to read?
I will. A 23-year-old G1 present to establish prenatal care. She brings on a list of general pregnancy-related questions. Which of the following statements are true? Yes.
Great, thank you. So I'll give you some time to think about your answers. So best answer is A and C, and this might be a little bit difficult to know without just reading through guidelines, but just to go over your options. So exposure to solvents such as toluene and benzene are associated with miscarriage, stillbirth, preterm birth, and also intrauterine growth restriction. So depending on, let's say, the patient's work environment, this might be something to think about. Regular exercise is generally safe as long as the risk of falls and abdominal trauma is minimized. So certain things like horseback riding, for example, you should avoid in pregnancy. Extreme heat, such as hot tubs and saunas, you should avoid in first trimester due to the association with neurotube defects, cardiac defects, and miscarriage. And then sexual intercourse itself is not contraindicated in routine pregnancies, except in situations such as placenta previa, and by itself is not a risk factor for preterm delivery. So these are just topics that, again, as I said, if you read through the tables that I highlighted from earlier in the articles that I'll share later, it will include this kind of information. Oops. So as I promised, I just wanted to share with you some resources that I find might be helpful for you. So the first two are articles you should be able to access in the American Family Physician Journal. They're both, and actually I asked Mario to attach this to the form, so you should be able to have that access to these also. And they're just useful, readings, review on very high yield topics for pregnancy care. The third resource down listed here is the CDC vaccination schedule, vaccination table. You may come across practice bulletins from ACOG on your OB rotations. They are also very comprehensive literature that you can refer to. And then lastly, I just wanted to share there's, if you're a busy resident, or even if you're not busy or not a resident and you just like podcasts, Creogs Over Coffee is a useful podcast on OB care. And they offer a lot of, or many 10 to 15 minute quick episodes on very high yield information. So it could be a quick review for you that you might find helpful. Okay, so I'll just leave you guys with the conclusion. We talked about how family physicians play an important role in providing maternity care, cervical cancer screening guidelines we went over, the multiple reasons for ultrasound evaluations, but how accurate dating is important to give appropriate management during pregnancy. Talked about pregnancy-specific vaccines and also COVID influenza vaccination. We went over routine labs, Group B strep screening guidelines, reasons for aspirin, and the importance of screening for certain psychosocial risk factors and referrals to treatment. And then lastly, we talked about different educational topics. And these are my references. And thank you all for listening. And I'll take any questions.
All right. Well, if we have no questions, Dr. Su, do you have any final thoughts you want to share with everyone?
Just wanted to thank you all for listening and yeah, wish you all the best in your training or your career endeavors. And I can also provide, maybe I'll give you, Mario, my email if anyone has any questions in general, not just with OB care, but any primary care related questions, you're welcome to get in touch with me. So I'll share that. Feel free to share that with the group too.
Excellent. Thank you. All right. So we have no questions. We'll go ahead and close out for today. Dr. Su, thank you very much for that great presentation. With that said, thank you all very much for joining us today. Have a great rest of your day and a great holiday season.